in the axial view, which you can see here, a B2 glenoid is a biconcave glenoid. So this, the top part of the picture is anterior, and the bottom part of the picture is posterior. You can kind of tell that because this is the bicipital groove here on the humeral head. So this is referred to, this original part of the glenoid is referred to as the paleoglenoid, and then this newly formed glenoid on the posterior aspect is called the neoglenoid. And I think we're going to be one of the very few companies that provides guided instrumentation for dealing with a B2 or a C glenoid, which are glenoids with significant posterior erosion. We are commercializing, like I said, a modular glenoid base plate that can be used for anatomic shoulder, total shoulder arthroplasty and reverse. So it will be a completely convertible system, both on the humeral side and on the glenoid side. And this is pending with the FDA right now, but we see the light at the end of the tunnel. So, and Arrow Prime was featured in a big way at the Academy last week, and it made a big splash. So I'm going to first go over the cannulated glenoid instruments, and then I'm going to go over the surgical technique. So this is the instrument. Some of us refer to this as the Paris Texas alignment guide. This is the instrument that allows us to position the guide wire precisely into the glenoid and to allow us to deal with the B2 and the C glenoid. So there are 6 guides. Each guide comes in a right and left, and then there's 3 options for posterior wear. No posterior wear, which means 0 degrees, 10 degrees posterior wear, which is what's pictured down below, and then a 20-degree posterior wear option. The stylus is removable. It's a little piece. Don't let it get lost, and it's unique for either a right or left guide. The reason the guides are right and left is because of the posterior buildup. And then you have a choice of handles to use. You can use either the number 1 handle or the blue handle. So just to summarize, there's a left and right guide. The guide is to the profile size of a 44 glenoid. You have the option for a buildup for posterior erosion of either 10 or 20 degrees. Be used with either handle, the blue handle or the number 1 handle. And then there's a threaded guide pin. Now the threaded guide pin is not yet marked like it's shown in this picture here at 47 millimeters and 79 millimeters from the tip, but it will be. And what those marks represent is 47 millimeters would be positioning this threaded guide pin without the use of the Paris Texas guide. So you would sink the guide pin to the first laser mark, and then you would be ensured that even the long post base plate would be accommodated because the long post base plate is 40 millimeters. The 79 millimeter calibration line would be the line that you would sink it to using the Paris Texas alignment guide, and this line then would end up flush with the top of the tower where I'm pointing with my mouse. So this is a 3 millimeter diameter guide pin, 170 millimeters long. And I've just explained to you the 2 calibration marks. So that threaded guide pin is already available, but with the calibration marks, that'll be coming as a single-use disposable instrument at the end of May. The big thing then, after placing the guide pin, is using these bow tie reamers. This is a funny little story. So there's one for every size. There's one for the 44, 46, 48, and 50. And we've been through 2 iterations on this bow tie reamer, and we got a version now that the doctors absolutely love. And what's nice about it is it's rounded leading edge right here. And at first, some of the doctors weren't crazy about these bow tie reamers because they thought they would catch a retractor and fracture the glenoid. And now those doctors that were most reticent to use it are now the biggest advocates of it. What happens is even if the glenoid retractor is in the way, This rounded leading edge just gently bumps off the retractor and keeps going without causing any disruption to the glenoid surface. So there is a modular handle that fits on each one of these 4 sizes, and then you continue to use your Zimmer Hall Quick Connect, and eventually this whole handle here will already feature this Zimmer Hall Quick Connect, and you won't need the adapter anymore. So we talked about the rounded leading edge, but even with that, I would suggest caution is required. Make sure they don't catch the retractor. Sometimes it is necessary to reposition the retractor or even take it out. It's best to debride the cartilage first with a curette for several reasons. You should do that. You should encourage the doctor to do that as the very first step, because when you go to put the Paris, Texas alignment guide on, if you haven't debrided the cartilage, any cartilage wear will put the guide in an erroneous position. So the guide works best when it's on native glenoid bone. That way you won't wrongfully position the guide with respect to version and with respect to inferior tilt. And it's always best to start this reamer before touching the glenoid surface, just like you do with the full circle reamers. And like I said, there's one for every size. The next instrument then is a cannulated drill guide. So now we're getting rid of the punches that we've been previously using in the original instrumentation to prepare the glenoid bulb, and instead we're using a precision drilling and broaching. So we use the existing 5mm drill bit, and we prepare a superior and inferior hole. So there is 2 keel drill guides. There's a combination one that fits the 44, 46, and 48, and that's because, as you well know, the keel for those 3 sizes is identical. So actually it's for the 44R as well, right? So you would use this combination guide for the 44, 44R, 46, and 48, and then there's a special keel guide for the 44S. Again, it can be used with either handle, the blue handle or the number 1 handle. It's to be used with the existing 5mm drill bit that already comes in your instrument set. And then there are new, longer stabilizing pins. You can use the existing stabilizing pins, or you can use these longer ones. Where it's longer is on the connection attachment to allow it to be easily grabbed with the pin. Here's a key instrument. It's a tapered reamer. This is for preparing the center hole and for removing the residual bone bridges. I'll show you more pictures of that in a second. And this will become a single-use disposable instrument by the end of May. Then we have these monoblock, meaning that the handle is already attached to these diamond tooth broaches. There's one for every size. You use it just like a file, an in-out motion. You don't do it all in one shot. And you certainly don't rock it AP, because that's the direction that you could create a glenoid fracture. And it's for that reason that when we design this handle, the overhang on the handle is only in the superior-inferior direction. There is no overhang of the handle in the anterior-posterior position, so that you can't disimpact it with an anterior or posterior torque. So it's off this same instrument that you'll make the winglet resection, or the anterior resection. And again, there's 4 sizes, one for the 44S, 44, 46, and 48. And the only reason there's a unique one for the 44, 46, and 48 is because of that anterior resection. It's proportional by size. Now then we have a cannulated drill. We have 2 of them. The first one is the standard length that's used for the all-poly center peg, the all-poly glenoid center peg. That'll be available as a single-use disposable at the end of May. And then we have one for the long post base plate. So this will be the very last step in the whole glenoid preparation over the guide wire. And it too will be a single-use disposable end of May. Both of these feature an AO quick pin. Other new instruments that are part of the Arrow Prime is we now have a new cancellous screw drill guide. What makes it new is this pilot, is the tip. You got this tip that fits into the countersink on the glenoid base plate, which ensures that you do not over-angulate the screw beyond plus or minus 10 degrees. Now, I'm sure that many of your surgeons have been doing that in the reverse shoulder, and you have quite a bit of grace to be able to do that because the glenosphere does not fit flush on the base.
Can you hear me?
Yes.
Yes, I'm sorry.
Who is that?
Who's that? Go ahead, Mike. I'm sorry.
Okay. So in a reverse, you have a lot of grace that the screw head could be left proud because the glenosphere does not fit flush on the base plate. You will not have any grace when we have the poly insert that snaps onto the base plate. So it'd be good now to get your surgeons used to getting that screw head flush or below the glenoid base plate surface, and this new drill guide will ensure that. I've had this question several times, so I thought I would address it now. Neither the existing drill guide nor this new one are currently calibrated to enable direct reading from the drill bit. In other words, when you do use the calibrated drill bit through this guide or the existing guide, you can't take a direct reading off the drill bit. That drill bit is calibrated for the cortical screw only. So, in the near future, we will have single-use disposable calibrated drill bits that will be calibrated for this new guide so that you could take a direct reading, and then you wouldn't need to use the depth gauge, but not yet. So just bear that in mind. If you guys are doing direct readings off the drill bit, I can't remember which direction it is, but you're either too short or too long with your screw. The new instrumentation also features a new depth gauge. It's a dual functional depth gauge. On one side, you read the graduations for a cortical screw, and then you turn the guide around and you read the calibrations for a cancellous screw. And the reason the calibrations are different is because the screw head on a cortical screw is 2 millimeters thicker than on a cancellous screw. So that's the difference in the calibration, 2 millimeters. Instruments that are coming soon. So we've been evaluating these pilot tip humeral diaphyseal reamers. So for example, if you're using a 10 millimeter reamer, pilot tip is 8 millimeters. If you're using a 12 millimeter reamer, the pilot tip is 10 millimeters. The advantage of that is it keeps you centered, and these are a little more aggressive in terms of reaming against cortical bone. We've also been evaluating this much more user-friendly, double-slotted humeral head resection guide, both a delta pectoral approach and a superolateral approach. No more funky assembly of how we've been doing it for the past decade. Basically, this delta pectoral guide is universal, left or right, so you flip it over, it becomes a left. There's a screw that assembles in this threaded hole here, and it goes onto this new alignment jig. So none of the old humeral head resection guide instrumentation is compatible with the new, and vice versa. So eventually this screw that goes onto this crosshead here will be captured, but right now just bear in mind that it's not captured. So when you loosen the screw, either take it all the way off so it doesn't vibrate loose and fall on the floor, or just thread it all the way in. These screws are compatible with a hex screwdriver. So there is a female hex on the end of the head of the screw. So if the screw's been tightened too hard and you can't get it loose with your fingers, or you want to tighten it more, you can always use the hex screwdriver. The feedback has been awesome. I'll teach you that from the top surface of this guide to the bottom of the first slot is 4 millimeters. And then from the bottom of the first slot to the bottom of the second slot, it's 5 millimeters. So what you do in the delta pectoral approach is you place a pin right in this hole right here, and then you lower the jig such that that pin is resting at the insertion of the supraspinatus, so the top of the rotator cuff. And then you would use the first slot when doing an anatomic total shoulder orthoplasty. And you would use the second slot when doing a reverse. There is some laser marking. It's difficult to see in this picture right here. It says 1.27 millimeters. What that refers to is the ideal thickness of the saw blade to use. So now that is a laser mark on the guide. Now the maneuver to disassemble this guide is incredibly easy, but it's different than what you're used to. You simply loosen the nut that's right here, that's not pictured. You back it out such that no threads are any longer visible. And then you loosen the nut that allows this alignment jig to be stable against the shaft of the diaphyseal reamer. And then you simply rotate the alignment jig on the shaft of the reamer until it clears the overhang, and then you simply lift up and off. So it's very easy, very, very nice. And we also have these single-use threaded 90 millimeter, 3 millimeter pins. They come single-use disposable in a 4-pack. So these are longer pins now, and they're threaded so the stability of the guide is really important. Now, something I just learned at the academy, so for those of you who've been using this instrument, this is new information for you. I had previously told you that on the delta pectoral humeral head resection guide, that all of the holes in the top row were parallel, and that the holes in the bottom row were divergent or convergent, like in our existing guide. Turns out that's not true. It's only true in the superlateral resection guide. But in the delta pectoral, in the top row, there are 2 holes that are non-parallel, as depicted by the red line. So just keep that in mind. That means that if you use one of those pinholes in the top row, you will not necessarily be able to slide the guide off the pins without first removing the pins, because you could theoretically have 2 converging pins, or 1 parallel pin and 1 converging pin. But depending how far the pins are in, you might not be able to get the guide off the pins without first removing the pins. Just keep that in mind. Other additional instruments that are coming soon is a new pin extractor. So this is a much narrower in this region here, so it can get between the pins much easier. And it's got this impaction surface at the top, which makes it very nice for impacting the stabilizing pins in the cannulated keel drill guide. So I'll show you that. And this is an instrument that most people really, really enjoy. It makes assembly of the glenosphere onto the base plate much simpler. Basically, it's a stick and grab, and so you don't have to worry about if you're turning the glenosphere counterclockwise, if things come loose. There's an arrow that lines up with the notch on the glenosphere, so now you know the orientation of the taper with respect to the base plate. And so you have a threaded handle here that locks, so then to release it once the glenosphere is in place, you just unscrew the one complete turn, the blue handle, top blue handle, with respect to this middle gray handle. And then the whole thing comes off the glenosphere, and you're done. You can form your single screw. So this is an inserter and an impactor at the same time. If you still feel like hitting it with the black cap afterwards, that's just fine. So there are 3 components. You got this gray plastic cap, this middle handle here, and then this blue handle. And it comes apart for easy cleaning and sterilization. When you reassemble it, to make sure that the gray plastic cap is tight and the arrow is pointing towards the glenosphere articular surface. pretty soon we're going to have a cannulated all-poly glenoid drill guide. And we've listened to the request of the surgeons. We've modified this guide so that we're no longer drastically over-drilling the depth of the peripheral pegs. So today we over-drill the depth of those peripheral pegs by 4.5 millimeters. That'll be reduced to 2 millimeters. We've not made a change to the central peg because that never breaks out of the glenoid vault. So that'll still be 5.1 millimeters for the preparation for cement. So that's coming the end of March. We will have this pin driver adapter that can be used for the 90 millimeter threaded pins that go onto a double slotted femoral head resection guide coming the end of April. And we're going to have these quick release drill bits. So right now, this is the 5 millimeter drill bit that already comes in your set for preparing the peripheral pegs of an all-poly and for the keel preparation in the cannulated keel drill guide. This will be replaced by these drill bits here that are leave behinds. So they snap into this adapter here, and then you drill and you leave it behind, and it becomes your stabilization peg at the same time. So no more drilling, exchanging with a stabilizing peg. Just do it all in one shot. So I showed you the top depth gauge here is the one that you currently are familiar with. The middle one is the one that I explained several slides ago. And the comments that we've had on that is some people really like it, and some people thought it was too big and bulky. And so it turns out that the gold standard is this black one here, which is the plastic prototype of the AO Synthes small thread depth gauge that everybody seems to like. So that's what's going to be coming, but we improved it slightly. So this little hook here at the end tells you the direction of the hook inside the bone. So now, no more guessing which direction is my hook. You know which direction it is, and you know how to easily get it out of the drilled hole. So flow profile, direction of the hook is known. It does fit and slide the screw sleeve for the sagittal cortical screw. And for those doctors who've been using the sagittal cortical screw, sometimes getting through that tissue percutaneously or transcutaneously is very difficult. So what you can do is you can take the stylus out of this depth gauge, out of either one of these, and then this hollow shaft becomes unobturated that fits through the screw sleeve. It makes it much easier to insert the screw sleeve through the tissues, just now you don't have a blunt end that's fighting and grabbing the tissues. So this will be coming end of April. Okay, so now you have a big picture overview of the instrumentation. Let's go through the surgical technique featuring the cannulated instrument. Okay, very first step is using what some people call the Paris, Texas alignment guide. This can be as complicated as you want or as simple as you want. So again, it comes in a right and left, a 0 posterior buildup, a 10-degree posterior buildup, and a 20-degree posterior buildup. You use it with the 170 millimeter threaded pin, and you can use either of the handles. Now, this stylus can be taken off. Most of our doctors so far are not taking measurements on their pre-op CAT scans to even be able to use the stylus. So they're just taking the stylus off and using it as a simplified guide. But let's say you are going to use the stylus and every feature of this drill guide. How would you do it? You need to have a CAT scan in the coronal or anterior view, and you need to have a CAT scan in the axial view. First, in the axial view, which allows you to see the anterior rim and the posterior rim, you can measure it with a goniometer, or most of the CAT scan systems have software that you can actually put lines on and make angular measurements or length measurements. We would measure the degree of posterior erosion, and if it's between 0 and 10, better to go down in size. If it's between 10 and 20, we would probably use the 10-degree guide. So here's where we make the assessment of whether we're using a 0, 10, or 20 degree posterior buildup. And then we make this measurement here from the anterior rim to a line drawn down the glenoid vault axis. And this horizontal measurement is what we're going to set the calibration mark on our stylus to. In the coronal view, we're going to make an assessment of whether there is any superior erosion. And then we're going to select one of our 3 holes, I'll go back a slide, up here, 0, 10, or 20, to give us the net desired inferior tilt that we want. So we're going to a bit more. So let's take this example here. So up in the top left-hand corner, I have a CAT scan reproduction of an axial view. I've made my measurements, and I've determined that there's 10 degrees of posterior erosion, and I've determined that the glenoid vault axis is 11 millimeters from the anterior rim. So therefore, and let's say that this is a left glenoid. So I'm going to pick the 10 degree left posterior buildup guide. Here's where you can see that it compensates for the 10 degree posterior erosion. And then in this view here, I'm going to set my stylus to 11. And I'm going to tighten this screw and lock my stylus in at 11. And now my stylus, when I put it on the bone, I want it to touch the anterior rim. Now, as I mentioned earlier, the profile of this guide is that of a size 44 glenoid. These little tangs down here, inferiorly, allow us to set our inferior position for either a 44 lining up with this edge right here, or a 46 lining up with this edge right here, or a 48. Now, it's difficult to see. We don't really ask that the doctor read these numbers, but you know that there's 3 sides. It's 44, 46, 48, and you know from the top view that there's 3 indentations. So once you just become familiar with the guide, you know that the indentation closest to the bulk of the guide is the 44, and the 46, and then the 48. So this is how you set your inferior position, because we know in a reverse, and also we're now teaching in an anatomic, that the base plate should be positioned flush with the inferior pole of the glenoid. I'll repeat that. That's for both the reverse and an anatomic. So, criteria. Inferior flush position first, coverage second. Okay, now we have to establish the inferior tilt. We've set inferior position. We've compensated for posterior erosion, if it exists. And now we have to set our inferior tilt. And you all remember that with an anatomic total shoulder, the net inferior tilt that we want is 0, or neutral. And for a reverse, the net inferior tilt we want is 10 degrees. That's really easy to do in a normal glenoid with no superior erosion. Now, let's say that in our coronal view, we have determined that there's superior erosion. And let's say that the superior erosion is 10 degrees. And we know that we're going to do an anatomic shoulder arthroplasty. And we know, therefore, that the pin should be in net 0 degree inferior tilt. But we have to compensate for the 10 degree superior erosion. So we're going to pick the 10 degree inferior hole, canceled out by the 10 degrees of superior erosion, nets us 0 tilt for an anatomic. Now let's take an example for the reverse. In the reverse, in a normal, non-deformed glenoid, we want to net 10 degrees of inferior tilt. Let's say we're presented with a glenoid that has 10 degrees of superior erosion. Well then, in that case, we're going to use the 20 degree inferior tilt hole, canceled out by 10 degrees of superior erosion, nets us 10 degrees of inferior tilt. Another way of doing a of taking these measurements is using this X-ray template that we've created that you can order from the Chicago office. So instead of taking measurements off of a CAT scan, you can use this template on your radiographs. And you can give a good estimation of your inferior tilt and for your superior erosion. Probably won't help you setting your stylus. Okay, so here's how the guide actually rests on the glenoid bone. It should be resting flush to the inferior pole with the stylus touching the anterior rim. This, I would say, is a non-deformed glenoid. Looks like I'm doing a reverse because I've got my threaded guide pin in the 10-degree inferior tilt pole. Okay, so now that you have a basic understanding of how this guide works, let's go through the surgical technique. First thing you do is you remove the glenoid cartilage. Then, with a bovie or a marker, you draw the coracoid scapular axis, which is from the foot of the pedicle of the coracoid process to the scapular spine. So that's typically like 11 o'clock to 5 o'clock. So you draw that line. And ideally, this pin will be positioned along that line once the guide is flush to the inferior margin of the glenoid. Like I said, most people are using the guide without the stylus. So you can use the stylus based on a measurement you've taken on the CAT scan. And then once you position that threaded pin, if it doesn't rest on that coracoid scapular axis, the doctor will probably reconsider positioning that pin. That is safe. So the most utility for this guide is being very precise, establishing the inferior tilt, and accommodating posterior erosion. Second step, so now we've removed the paratextus guide, we're left with the guide pin in place, and we insert our bow tie cannulated reamer, and we ream in standard fashion. Just be aware that these reamers are a little more aggressive than what you've been used to with the full circle. Reamer comes off, and you'll notice that in the case of a reverse, if you've got your inferior tilt properly done, you will have reamed away your bovie line marking the coracoid scapular axis south of the equator, but it will still be there and present north of the equator. That indicates that you've got good inferior tilt. If you had reamed that away and there was no more bovie line showing, you've either over-reamed or you don't have, in the case of reverse, adequate inferior tilt. In the case of an anatomic, you would have completely reamed away your bovie line because you're doing it at 0. Okay, so now in the case we're doing a reverse here, or we're doing, it doesn't have to be a reverse, it could be a metal back modular base plate once we had it cleared by the FDA, or a total shoulder arthroplasty. So what I'm depicting in all this procedure here so far is cannulated instrumentation for a modular metal back keel base plate. So now this keel drill guide has laser mark lines that line up with our bovie mark, and it fits over the guide pin. If you need either handle, the handle is typically on the anterior side of the guide. And then we drill our superior. Let the surgeon drill whichever hole he wants to first. You'll get the most stability by drilling the inferior hole first and then stabilizing it. But the inferior hole is more difficult to access. So to access it twice, first to drill it and second to stabilize it, is a little bit of a struggle. So most surgeons are drilling the superior hole first, stabilizing it, but in the case of a reverse, only a little bit of that stabilizing pin is engaged in the bone because you have the gap because of the inferior tilt, and then they drill and are finished once they drill the inferior. So here we've drilled the superior hole and stabilized it. Now we drill our inferior hole shown in step 6. Now we remove the guide, and you can see that we have our threaded pin in place, and we have our superior hole and our inferior hole, and now we use a cannulated tapered reamer and prepare a center hole. And the center hole then also gets rid of most of the residual bone bridges. So now we have a snowman, but the middle ball of the snowman is bigger than the top ball and the bottom ball. So I just want to show you the shape of what we've done here. So these drill bits, this is your standard 5mm drill bit that you've always had in your set. You can see that we're just following the shape of the keel. So at this point, in hard sclerotic bone, before we go to the broaching step, it would be best to take a rongeur or a burr and completely remove those bone bridges. In soft bone, this broach easily breaks through those residual bone bridges. Like I described earlier, there's one for every size. There's one for the 44S, 44, 46, and 48. Once we get it flush to the inferior surface, which we can see through these 2 windows, and again, there's a laser mark line here to line up with your drawn coracoid scapular axis. You do an in-out motion. You don't try to do it all in one shot, and you certainly don't hit the handle in a retro impact anterior-posterior, because you don't want to fracture in this direction. So you toggle it in and out, superior, inferior, to get it in and out. Once it's down flush inferior, you just, as you've been doing in the past, you use a saw blade and you make your sagittal anterior cut. And then, if you're using the long post base plate, the very last step is using the cannulated drill that's now available over the guide wire. Now, I'll just teach you right now, the guide wire is 170mm long. The cannulation in the long post cannulated drill bit is 160. So, if the doctor doesn't feel like, if you've noticed, the doctor notices that this collar is not yet flush on the bone and is meeting resistance, it means that the guide wire is not being inserted deep enough. So at that point, take out the drill bit, either insert the guide wire deeper into the glenoid vault and finish it with the cannulated drill bit, or remove the guide wire and finish it with the cannulated drill bit, which will follow the path that it's already taken. And then finally, for a reverse, we have the glenosphere positioner impactor. And I'm sorry, my language here just teaches you how to assemble and disassemble. So you don't have to disassemble the blue handle from the gray handle. One full turn counterclockwise, and the engagement mechanism is deactivated, and it easily releases from the glenosphere. Okay. What are the few steps required for an all poly? So you use your colored trial sizer, or you could use the Paris, Texas guide as a sizer. You're going to mark your hole. Again, you would have drawn your coracoid scapular axis. You would have gone for inferior flush on the glenoid spine and for coverage. And then through the Paris, Texas guide, we're going to insert our guide pin. So obviously, in this picture here, we're using the 10-degree inferior tilt hole because there must be 10 degrees of superior erosion. Otherwise, we would use this top hole in a normal, undeformed glenoid, because the top hole is 0, inferior tilt. Then we use our bow tie reamer in standard fashion. Then we come in with our standard 5mm cannulated drill bit over the guide wire, and we create a center hole for the center peg of the all poly. Then we put on our existing template drill guide. We stabilize it in the center hole, and we drill our peripheral holes and stabilize it. Okay, so that's the steps. It's pretty straightforward. Like I said, and Greg said, the feedback from the surgeons has been fantastic. For those of you that get the opportunity.
Mike, this is Greg. Just let me interrupt just for a second. So all of you know, this is very, very technical information, and I hope that we haven't lost you on this explanation. But be aware that in Chicago in late May or early June, we will be having a distributor rep distributor training, sales rep training, to go over all of this again. This is not meant to be the definitive training on this. So just plan late May. We will get word out to you in about 2 weeks about the dates for a Chicago training to review this when we know that all sets will be available and can be sold and shown in the field. So just don't be overwhelmed with this. Just bear with us a little bit.
And it's really easy. So if you get a chance, you can talk to people like Greg Cardenia, Brian Mack, Phil Gritzmaker, Steve Jones, Shelley O'Day, who I left out? Larry Lampazona. I think they all could attest for you how easy it is to use this instrumentation, and the learning curve is incredibly short for both the sales rep distributor and for the doctor. For those of you that will have the opportunity to begin using this instrumentation, it is vital that you complete the surgical evaluation forms. So when you accessed this talk in the Dropbox, there were surgical evaluation forms in there for you to download and use. I encourage you to submit those forms completed back to me within 24 hours of the case. Okay, there was a new published paper that came out in February in the Journal of Shoulder and Elbow Surgery. The title of it is "The Main Cause of Instability After Unconstrained Shoulder Prosthesis with Soft Tissue Deficiency." And this is on the Arrow system. So let me go over it with you. This is a retrospective multi-center study. It was based on 532 total shoulder arthroplasties, excluding all reversals, done from a 10-year consecutive period from 2003 to 2015. Of these 532 primary total shoulder arthroplasties, 116 were hemis, 149 featured the all polycemented glenoid, and 267 featured the cementless metal back that were desperately waiting for clearance from the FDA. So over a 10-year period, there was a 5.07% postoperative instability. So out of the cases with the cemented all poly and the cementless metal back, so excluding the hemi, there were 27 cases of postoperative instability. So there's something we can learn from that. That's comparable, by the way, to what's been published in literature for other brands. So we can see here, so HA is the hemi, TS, ACG is the total shoulder arthroplasty cemented glenoid, and TSAMB is the metal back. So you can see the breakdown. You can see how many patients were lost by group, how many patients were left after those that were lost to follow-up, and you can see where the breakdown on the 27, where they come from. So most of them were in the metal back group because the metal back base plate was used for those difficult B2 and C glenoids. So it's not, and you can see the breakdown here, how many of those B2 and C glenoids were done with the metal back versus an all poly. So those are the more challenging ones. So for the 27, let's talk about it. Mean age was 66, ranging from 42 to 83 at the time of the index surgery. Reasons for the index surgery, so 13 were from permanent osteoarthritis. 6 were after recurrent anterior dislocation. 3 had an acute 4-part humeral fracture. 2 had a proximal humeral fracture, and 2 had a post-traumatic osteoarthritis. And 1 was posterior spilic after a ladder J. So for all of them, if they had a type B or C glenoid, retroversion was attempted to recreate the native glenoid through anterior reaming and posterior bone graft. The humeral component was always implanted in 20 degrees of retroversion with a transosseous repair of the subscap. The mean time to instability was just after a year. So it can range anywhere from 1 month post-op to 10 years post-op. Most of it occurs very quickly, in less than a year. Main cause of instability was tissue imbalance from a subscap tear and or a massive rotator cuff tear. So not, some of it's surgical error in terms of positioning, But some of it is just a weak rotator cuff that eventually ruptures, or a weak subscap that ruptures. So in these 27 cases, 10 of them were from a subscap rupture, 6 of them were from a massive rotator cuff tear, 8 of them were due to a technical error in terms of malposition. 5 of them in the glenoid, 1 of them in the humeral, 2 of them in both. And there was only 1 instance of metal back glenoid base plate loosening. So this is the kind of data that we look for when we're launching this new product that's pending FDA. And there was only 1 dissociation of the poly insert from the metal back base plate, and that was before the design change was made. And so the version that we're introducing in the United States is the version after the design change, which occurred years and years and years ago. And since that design change, there hasn't been a single dissociation. And there was 1 instability due to humeral short. So again, this is just a little bit of a breakdown again. You can see where which groups the problems of the 27 belong to. So what was the treatment for instability? 2 of them were left untreated. 1 of them had a closed reduction. 2 of them had bone blocks. So basically what you do is you take a piece of the core process as a vascularized graft, and you use it as a block to prevent the humerus from dislocating off of the glenoid. In 2 cases, the L-polyglenoid was repositioned. In 1 case, the humeral stem was repositioned. In 1 case, the subscap tendon was repaired. And then here's the big point. 18 of the 27 were converted from a total shoulder arthroplasty to a reverse. And in those 18, the humeral stem was able to be left as is, intact, 16 out of 18 cases. So that's an 89% success rate. So that's even better than our other published paper, which said that 25% of the time, the humeral stem had to be removed and more humeral head resected, proximal humerus resected, in order to reduce for a reverse. So 10 to 11%, or okay, like 89 to 90% complete convertibility on the humeral side now from an anatomic to a reverse is just huge, fantastic. So what were the results? At a little over 3-year follow-up, no periprosthetic loosening or component shift at last follow-up. That's great. No scapular notching. No fracture of the scapular spine or the acromion, which means we didn't put excessive stress on the delta, on the acromion. 1 out of 18 of the RSA conversions failed. It failed after a closed reduction. It dislocated again at 2 years due to humeral shortening. There were no other instabilities in each 27. All clinical outcome measures improved with statistical significance, except for external rotation with abduction of the arm. So here's all of those clinical outcome measures. You can see that the p-value is less than 0.005 in all cases except for ER2. So what's the take-home message here? The incidence of instability was 5.07%, which is comparable to other published studies. The main cause of instability was tissue imbalance due to subscap tear and/or massive rotator cuff tears. In such cases, conversion to a reverse is simplified with a completely convertible system on both the humerus and the glenoid side of the joint. The humeral stem was retained 89% of the time in conversions from a total arthroplasty to a reverse arthroplasty. And it means follow-up of 3 years. Here's the key point that we're going to use to market the conversion from a metal back base plate for an anatomic to a reverse. So at 3 years, a metal back base plate that's been initially implanted without inferior tilt because it was done for an anatomic and converted to an RFA shows no sign of radiolucent lines or incidence of scapular notching or acromial or scapular spine fracture. That's an incredibly powerful statement backed up with clinical outcome data. Okay, and last, you may or not be aware, but you should, that there was the most serious of all recalls possible of the Biomet Zimmer Comprehensive Reverse Shoulder System. It's a Class 1 recall. This is the part that's affected. It's this metal tray right here that holds the poly insert. And the one specifically that was under recall is the 115340, which is the workhorse. It's the 40 size 44, 0 millimeter offset. So they can't do reverses now without this product. And what's breaking is this post, this stabilizing post that goes into the humeral stem. It's just fracturing off the base plate. So it's a Class 1 recall because the fracture rate of the humeral tray was higher than expected. We don't have any fractures of ours, by the way. And you should be aware that Class 1 recalls are the most serious type of recall, and it involves situations where there's reasonable probability that use of the product will cause serious adverse health consequences or death. So you can click on this link here. You can learn a lot more about this recall, but I would say the opportunity is there for you to call on those doctors using the Biomet Zimmer Comprehensive Reverse System and show them ours. Okay, Greg, that concludes my portion. We can see what questions we got now.
Very good. Thanks, Mike. I appreciate it. And again, just let me reiterate, that was very technical information, and we do have training scheduled to review and go over this stuff again. So we will be able to be much more proactive in making sure you understand all these concepts, because it does simplify. Even if it didn't look like it was simplifying the system, it simplifies the preparation of the glenoid, and it is more exact in the preparation of the glenoid with regards, especially to the reverse, because of the cannulations and the cannulated instruments. So let me just check down here, see what we have in terms of, does anybody have any questions? I've got a question.
Greg, did we record this?
Yes, we did.
Great.
We recorded it. It started about 2 or 3 minutes after you were talking, Mike. So it'll be okay. It'll start with your presentation in process, but just about a minute or two into it, I think. So
okay. Janet and her team will be emailing everybody that link to that recording. Other questions?
Hey, Mike and Greg, this is Greg Cardina. Hey, real quick, I got a question. The comprehensive system, that was originally just Biomet, correct? When they merged, that system came from Biomet? Okay.
Yes.
Okay.
Jeff Cunningham. Jeff. Yes. Most everybody has a cannulated system. I think that we have a better one now, especially with our Paris, Texas alignment guide, that it can, and there'll be even a further enhancement of that we're working on that'll allow us to really handle the B2 and the C glenoid better than anybody else.
Mike, question for all. How many companies currently have instruments for superior lateral approach, and who are they? I think everybody would have instruments, or there's not instruments specifically for the superior lateral approach, Mike, but everybody would be able to do a reverse, I believe, with the superior lateral approach. Some may be easier than others, but that's a surgeon preference in terms of the approach that they want to use. Most people use a delta pectoral, but some are exclusively superior lateral when it comes to reverse. It just makes drilling and reaming and getting a inferior tilt much more difficult because you're coming from up top.
Yeah, what people like about the superlateral approach is the visibility of the glenoid. The visibility of the glenoid is just fantastic, but at the sacrifice of a little bit of stability.
Okay, it is now. Oh, go ahead. Go ahead, Mike.
Nope.
Okay, it is now 9:01, and I don't want to make this too long. We plan on doing other webinars beginning in May, And so I want to make sure that you all participate. So we're going to close this down. I appreciate everybody doing that. There is Michael, where's the test again?
It's in that folder
In the folder
in Dropbox.
in Dropbox. So you fill that in, you send it in, and we'll send you a $10 Starbucks gift card. And send it to me, to my email. And if you remember, my email is g.sherburn@fhortho.com.
Thanks, everybody.
Thank you all very much. I appreciate it. We will be looking forward to hearing from you.
Thank you, guys.
Bye.